people living with dementia. Sorry. There's obviously a lot more people living with dementia nowadays, as fortunately there are fewer people dying young. So there are more older people, but within that, there has been an age-related incidence decrease of about 25% in some high-income countries, including US, Europe, and the UK over 20 years, indicating a potential for prevention. Something has changed. And that something is such that, you know, if we had drugs, we would say everybody should take them, because that's a remarkable figure. Nonetheless, the numbers are stable or increased in some countries, in the East, in South Asia and in South America, suggesting that dementia is potentially, but not inevitably, preventable. It depends what you do. And the mechanisms are thought to be to increase cognitive reserve and resilience, of which I'll say a little bit more in a minute, and a reduction in damage, particularly vascular, but also inflammatory damage, rather than a reduction in, say, plaques. The improvements either within the high-income countries or in higher income, more educated people, and in men more than women to an extent. And that indicates that even in these countries, there's a huge continuing potential for improvements. So I said I'd say a bit more about cognitive reserve. So this is a paper from the Lancet, nothing to do with me. And if you look at the bottom left slide, which looks at cognitive impairment and dementia compared to the amount of neuropathology, you will see that as people have more neuropathology on average, then they tend to have more cognitive impairment, as you'd expect. However, if you look at the other graphs above, which are the graphs of individuals' neuropathology, you will see at the top left, these are people who had high cognitive performance, no impairment at death. And then at the bottom right, these are people who died with severe dementia. And there's a huge overlap in the amount of neuropathology between these people, indicating that neuropathology is part but not the whole problem. Some people with neuropathology do not have dementia, and the converse is that some people with some neuropathology but not very much, a lack of cognitive reserve, develop dementia. So a huge overlap, and that would indicate that tackling the neuropathology might be helpful, but it's not going to be the whole story. So we wanted to think one of the things that we decided to do within these Lancet commissions was to consider what the risk factors might be for dementia. And if you look at the literature, there are a very large number of candidate risks. And we decided that we would consider what risk factors had enough evidence to include. And we all sit in a room for 2 days at a time with individuals presenting the evidence and the group talking about them and coming to a decision based on the evidence. So we wanted to include high quality studies with a consistent dose-responded, validly measured decrease in risks that were biologically plausible, that preceded dementia, remaining when measured a decade or more before onset, where changing the risk factor made a difference. And these were the sort of ground rules. And we looked at existing evidence. And on top of that, we did searches, we prioritized systematic reviews, we had expert inputs considering how good the evidence was. And I think that's sort of different from just general expert opinion. It was experts' opinion about the evidence rather than what they thought off the top of their head or what we thought off the top of our head. And we added in the 2024 new systematic reviews for depression and hearing loss, but we'd previously done other systematic reviews for head injury and alcohol. And within that, we calculated the population attributable fraction And that's the fraction theoretically prevented by eliminating an individual risk factor. So there's two important things for that. There is how big the risk is, so what the relative risk is, and how common the risk factor is, the prevalence. And it's broadly, slightly more complexly, but broadly, it's that you work it out by relative risk times the prevalence of the risk factor. And we used all-cause dementia as the outcome for a couple of reasons. First of all, most dementia diagnoses don't have neuropathology. And secondly, most people who die with dementia, who have dementia, have it in late life and have a variety of neuropathologies. It's not just one. We used international data, but we were aware that risk differs both within and between countries, and also that the international data is skewed. So the international data comes more from high-income countries, although the majority of people with dementia live in low and middle-income countries. And from that, we agreed on 14 risks. We know there are others, but these were the 14 that we thought the evidence was good enough. And within that, we adjusted for communality. And by that, we mean that if you have a lab rat, you can possibly give them one risk factor, but people are not like that. They tend to have multiple risk factors, and these multiple risk factors cluster. So the person who doesn't take exercise is more likely to be obese, more likely to have diabetes, more likely to have high cholesterol, and more likely to have hypertension. So we considered the fact that a relative risk would not necessarily be part of just the individual risk, but might be because of the risk cluster. And within the paper, and I won't go through it now, we have both the equations and the code so that other people can do it if they wish. And here are their 14 risk factors. I'm not going to read them all out because I don't think that will help, but I want you to notice that most of them were in midlife, and that within that doesn't necessarily mean that they stop at the end of midlife, but it means they start in midlife. But there are hypertension and obesity, which paradoxically, in late life and older people who are developing dementia, their blood pressure goes down and they lose weight. So at the point of just as they're developing dementia, they are much less likely to be hypertensive and obese. But most of them are in midlife, some in late life and some in early life. And I'm going to talk a bit more about most of the individual ones. First of all, I want you to see this is our table, and what it shows is the relative risk, the prevalence, the communality, which makes us think that people have several risk factors, and the unweighted population attributable fraction and the weighted ones. I don't want you to look at all of these numbers, but I want you to notice that most of the numbers are reduced by about 2/3. If you consider communality. So it's terribly important to think about what other things an individual might have, and it varies between different risk factors, but approximately 2/3 with each. And then I'm going to show you the infographic that we drew using this. I have really one piece of advice for any of you who want to be known, and that is draw a nice picture, because I almost never go to a conference where somebody doesn't show this picture as well as me showing it. I just like to see, I also wish I'd copyrighted it, because then I might be a bit richer than I am. However, this shows, if you look at all of these risk factors together and you add them up, they make approximately 45% of potentially modifiable risk factors. And that is considering the whole world together and the evidence of the whole world. And the one with the highest risk, which I was initially I'm very surprised about, but I'm no longer surprised. I got used to it, was hearing impairment. It was then the next one is high LDL. Both of them are very common, and that makes a difference. And then followed by less education and social isolation. And as we've done this, less education has gone down because fortunately education within the world has tended to increase. I want to talk about education. I think we've known for a long time that education is important for cognitive reserve, that people who have more education, who go to school and have more qualifications at school and have leave later, are less likely to develop dementia. But what I think we've only known recently, using very large cohort times, is that people who have little education but cognitively stimulating jobs have protection. So people with cognitively stimulating jobs but little education compared to people with cognitively stimulating jobs without education have 20% decreased dementia risk. And people with both cognitively stimulating jobs, people with more education have 27% decreased, and people with both education and cognitively stimulating jobs have decreased dementia risk of 37%. And my colleague, Mika Kivamaki, led this. I'm one of the co-authors, and he looked at the proteins and found that cognitive stimulation at work is associated with a decrease in the proteins which inhibit CNS axonogenesis and synaptogenesis. So everything works biologically. So environment is important, lifestyle is important, social factors are important, but they all work within the body biologically. And lower levels of these proteins are also associated with dementia risk. There's also some evidence that retirement may increase deterioration cognitively, even allowing for ill health. So it looks like cognitive stimulation throughout the life course is very important. So hopefully all of us are at the moment busy feeding our brains and increasing our cognitive reserve. So I started with education because that's mainly, that starts off in young life, and I wanted to move, on to hearing loss. So I was initially very surprised that hearing loss seemed very important, but as I said, no longer. And there's a consistency in studies which show that people with hearing loss, which is objectively measured, and if you follow them up over a longer term, 6 to 12 years later, there is a dose-related risk. So if people are, the worse your hearing, the more likely you are to develop dementia. But if you wear hearing aids, then you are much less likely to develop dementia. And cohort and randomized controlled findings find that wearing hearing aids reduce dementia risk in people at risk. And I'm going to talk in another second a bit more about the Lind study. And there's another study looking at MCI in dementia and finding that wearing hearing aids doubles the time with developing dementia. That's a cohort, not a randomized controlled trial. So as I say, people with hearing aid who used hearing aids compared to those who did not had a 19% lower risk of cognitive decline and a 17% lower risk of dementia. And the people in the Frank Lin randomized controlled study from the United States, he'd had two groups within the study, and I think it's just very important as it illustrates the thing. So one group were healthy volunteers. Healthy volunteers tend to be much healthier than the rest of the population. And there was no difference between groups. Neither group had cognitive deterioration. Both groups improved. But he also had a group from a long-term cohort study, the ARIC study, very famous study, and they were more likely to smoke, had less education, were much iller and were older. And there was a massive difference between the groups in using hearing aids in the randomized controlled trial. So I think it's very important to consider, it's important to have a population if you're going to try to prevent dementia who are at risk. And that's probably one of the reasons why it's very interesting that Manuel's doing it in MCI groups, because these are groups who are likely to develop dementia, although not all of them will. Let me move on to cholesterol. It's really common to have high cholesterol. There's a lot of more evidence. We added this risk factor in 2024. There's a lot more evidence that it increases dementia risk, and particularly in people who develop at age less than 65. And as we look at people who are likely to develop more than 10 years later, and we're interested in the time because we're considering the direction of causality. If it's 10 years later, it's highly likely that cholesterol causes dementia rather than vice versa. Statins in midlife in cohort studies and in emulated trials decrease the risk of both dementia and death. And I think it's a clear opportunity to prevent dementia with statins for high cholesterol. It's quite cheap and well-tolerated treatment. And move on to smoking. I'm not going to say much about smoking because you never really meet a doctor who thinks anything but that people should just stop smoking. Interventions for cigarette smoking are working quite well. There's been a decline in most countries, certainly in high-income countries, although not in a decline in other countries where where people are allowed to advertise and where there's been much more concentration. I think what's really interesting about smoking is that in both London and Britain and in Korea, when people stop smoking, around 2 years later, smoking quitters have begin to lose their excess, and by 3 years they appear to have no excess risk of dementia. So it seems to be that it's really, you might have smoked for your whole life, but if you haven't developed dementia, it's not too late to stop, and it can make a big difference. Moving on to depression. So for some years, we have been wondering about the direction of causality, whether dementia causes depression or depression causes dementia. And I think it's bidirectional. That people, as their brains become more vulnerable, are more likely to become depressed, but also people who develop depression in midlife are more likely to become depressed. And for the first time, we were able to do a meta-analysis of dementia 10 to 14 years after depression, and we were able to find a hugely increased risk of dementia. It was also a very interesting study in UK Biobank, which found that while people with depression had a higher risk of dementia, those treated had lost their excess risk, and that was with either antidepressants or psychotherapy or both. And the untreated but remitted group, so some people just get better from depression, also lost much of their excess risk. Moving on to air pollution, there's not a lot you can do about your own air pollution, although it might be a good idea not to have wood fire inside your home with the windows closed a lot of the time. But other than that, you can't do much. But studies consistently find that that anything that increases the PM 2.5 particulate matter, doesn't matter really what it is, they can increase the risk of dementia. And interestingly, there's been several natural experiments which have changed what's happening, and they have reduced both dementia and cognitive impairment compared to the groups which did not. So it looks like that really makes a difference as well. Excessive alcohol consumption. So 21 UK or 14 US units a week is anything more than that is excessive alcohol consumption. There's a non-linear effect. Similarly to cigarettes, the South Korean cohort found that people who stopped drinking to excess, and by excess I mean drinking sort of a large glass of wine a day rather than actually being drunk and having alcohol dependence, but people who reduced it reduced the risk of all-cause dementia. If you look at studies, they report that people who have moderate alcohol consumption are less likely to develop dementia than people who don't drink at all. I think that might not be true because a large number of people who report not drinking at all are previously heavy drinkers, and quite a high number of non-drinkers die of alcohol-related liver disease. But I quite often will choose to believe that it is true and have a drink over the weekend. So I don't, I think if it does harm you, it certainly doesn't harm you very much, but excessive alcohol consumption makes a big difference. Moving on, because 14 is a lot. Treating high blood pressure reduces the risk of dementia. These is from meta-analysis, because all studies of high blood pressure, all randomized controlled trials tend to be abandoned because the non-intervention group does so badly. Traumatic brain injury, I think we've always known it's not very good for you, but what we didn't really understand is that it's not just something which lands you in hospital, but there's much smaller head injuries can make a big difference, and there's much more evidence linked with some sports and with whiplash and head contact, with rugby football having the highest concussion rate. So TBI is probably something that is mainly preventable from things like seat belts, cars, and people wearing sports things. I'm not sure that being part of the army you can do much about it, but other things you can. Physical inactivity, exercise and fitness is been known for some time that it makes a difference to develop dementia. And I think importantly, the reduction in risk is greatest when you move from being extremely sedentary to having some physical activity. So you don't need to be doing ultra marathons, just moving a bit can make a big difference. In cohorts, exercise at any age is helpful, but there's little randomized control benefit, and that's possibly because the duration and type is unclear. But it's also interesting if you look at these cohorts, which these randomized controlled trials, which tend to recruit highly motivated people, you find that the non-intervention group all exercise as well. So that takes away from any effect. Diabetes, midlife diabetes is a particular risk, and that might be just duration and causing more damage. But interestingly, randomized controlled trials indicate that GLP-1 receptor agonists associated with decreased dementia risk of around about 50%, so a massive decreased risk in this high incidence groups. One of the other relatively new things is untreated visual loss. Visual loss is common globally, less common in high-income countries. Untreated vision loss of any type is associated with increased dementia risk and increased risk of cognitive impairment, and that is dose-related. Interestingly, treating cataracts and retinopathy makes a big difference, but glaucoma doesn't have an increased risk. And I didn't know this, but read recently that people who have ApoE4 are protected from glaucoma. So this may be a group of people who are particularly less likely to develop dementia. For people who did have cataracts, those who had cataract extraction had no increased risk, and there's clear opportunity for dementia prevention by treating visual loss. Let me move on to multi-domain trials. I'm talking about trials which have been, which are for people without cognitive impairment. The Cochrane review found 9 multi-domain randomized controlled trials and found a small effect on global cognition with a Z-score mean difference of 0.03. That's on a scale which goes from 0 to 1. Since then, there's been several studies. There's been a pointer study. It had a similar effect size, and I'm going to talk a little bit more about it in a minute. But the pointer study, which is one of the global fingers study, so fingers has gone global, but people have done it differently, had self-guided v structured intervention. So both intervention groups had an intervention, and both of them improved. And again, the effect, the Z difference was 0.03. A study in Britain, Apple Tree, had a similar effect size. However, a SMART trial, which had, instead of just giving everybody the same and hoping that they did rather better with it, it had both coaching and personalized goals. So people changed what they tried to change, and they had coaching to try and help change their behavior. And it had a much bigger standard mean difference of 0.14. And similarly, the Mind Your Brain study in Australia from Henry Brodiety had a very big standardized mean difference of 0.18. And it again was personalized. It was online, and a third didn't open the app. A third did some, and a third did most. And it looked at physical activity, nutrition, cognitive activity, and depression or anxiety. And it makes you think how much better people might have done if they managed to get more people to do it. And Achieve, which is the study I talked about with hearing aids, no effect in healthy volunteers, but with people with multiple risk factors, they had a 40% decrease. So multiple component intervention trials tend to recruit highly educated people who we know are at less risk. So Pointer discusses how they had a relative ethnic risk mix, but 95% of people had a degree, and more than a third had postgraduate degrees. So these are highly motivated, highly educated people, and many of them in the control group probably followed the intervention. Most of them are not personalized. Everyone gets, say, dietary or cognitive and exercise intervention, and that may be not what they want to change, and may not even be what they need to change. So their diet may be good, or they may have high exercise. There's often low adherence, and with all studies of dementia, it's a long-term risk, so it's hard to see. So mainly people have to look at cognitive change. I think the way forward is tailoring to risks, only do things for people risks that people have and that they choose, having online programs to make it scalable, targeting risky people, and coaching so that it will be sustainable with an increased effect. Overall, does changing risk factors change outcomes? Yeah, I think it does. Use of hearing aids, air pollution, hypertension, education, smoking, vision, depression, all of these things. But it's important to make changes with people at risks and not recruit low-risk people. And I want to move on to thinking about population attributable fractions instead of globally, thinking about it within and between countries. So this is Canada. It's not my paper. This is, and if you look at paper, if you look at it, it's 12 modifiable risk factors, not 14. So it was written before we had added visual loss and cholesterol, and it decided to replace pollution with sleep disturbance. And I don't agree that the evidence is that sleep disturbance is part, but a lot of people think that sleep disturbance makes a difference. I think sleep disturbance in late life is probably more related to, it's probably more that people developing dementia have sleep disturbance, although I completely agree that they're associated. However, with these 12 risk factors in Canada, they found that nearly half of dementias were potentially preventable. So a hugely important within Canada, and hugely interesting paper. I wanted to go on to the next one. It will. This is looking at Brazil, and Brazil is, of course, a middle-income country. And it's also looking at 12, but it's finding two things, that it's got higher risk than we found with 12 risk factors, which was about 40%, but also that they're higher in poor regions than rich regions. So another 5% difference in poor regions, and they probably massively underestimate it, because things like hypertension were only known about if somebody, and diabetes, if somebody had seen a doctor. So it didn't find any more diabetes in poor people than in rich people, whereas we know that that tends to be a real difference. So it's a difference within countries. And in New Zealand, we did this study, and I think looking at it in people with different ethnicities, self-identified ethnicities, and you'll be probably not surprised to know that the risk is much bigger, or was much bigger, in Maori people and Pacific people than it was in European, and East Asians had even less risk. I just want to talk a little bit about cost. We looked at cost of individual things, and we found that hearing aids, antihypertensive, and smoking saved money, but preventing diabetes at that point did not. And when we modelled policy, we found that within England, because you have to do health economics in a country, because things cost different things in different countries, that decreasing the salt in food that people just buy should decrease the cost of dementia by 2.4 billion pounds, and decreasing sugar by 1 billion pounds. Alcohol, decreasing air pollution, and smoking, compulsory helmets for cycling, all should save money. So Manuel talked a bit about changes. The US Congress put forward a new goal to reduce the burden of risk factors, to aggressively address 10 potential risk factors, and consulted and made them a target. Changing the subject entirely from prevention, I want to talk for a minute about anti-amyloid therapy. I think probably all of you will know that we're now living in an era of at least theoretical anti-amyloid therapy, with lecanemab and donanemab, monoclonal antibodies which target and clear amyloid protein brain plaques with remarkable efficacy. We're able to see a massive decrease or none in people's brain. They've been tested in early stage Alzheimer's disease, and they're effective for amyloid, but not very effective for cognitive symptoms. So the CDR sum of boxes finds a differential decline of 0.45. So that's and which is something, but not massive. But both groups continue to decline over a period of 18 months. It's burdensome. It requires genotyping, because a Side effects are particularly in people who are ApoE4 homogeneous, and it requires MRIs to keep seeing it, to check for side effects, and it needs to be given intravenous by infusions in hospitals or clinics. ARIA homozygous, depending on which drug, get around 1/3 to 40% of ARIA-E, which is an illness which was entirely, the description is made for anti-amyloid therapy, didn't occur before. And that's 12% in heterozygotes and 5% in non-carriers. So, but most of these are, despite the fact people have bleeds, most of these are asymptomatic. The costs are high, of $26,000 a year, and that's without the screening for eligibility, the administration, and the monitoring. And we're continuing to wait for more trials. So they're revolutionary in a way because it's the first drug which is said to be disease modifying, or they are the first drug said to be disease modifying. We're waiting more trial results in particular groups, so in people without dementia, and also in people with a genetic early onset dementia. And I think people are excited, and we can hear people keep telling me that they know what the results are. I don't know what the results are. I don't think the drug companies know what the results are, but it's important and could make a big difference if it prevents people getting dementia, as opposed to the relatively small decrease. In Canada and in Britain, they are approved but not funded. So these are graphs from the paper. If it's disease modifying, what should happen is that over a period of time, the two groups get further and further apart in cognition. Whereas if it's just treatment, then the two groups should diverge and then remain approximately the same stage apart. I think if you look at the top, which is cognition, it's not clear to me that they are diverging further. It's very clear on B, which is the amyloid burden, that they are diverging, but it's not so clear in cognition, and the numbers aren't given, so you have to sort of sit there and squint at it and try and work it out. But I think it's not terribly clear that they're diverging further over time. Because, of course, even if they only work a bit to begin with, if they kept working better and better, that would make a big difference. We've also got other drugs, cholinesterase inhibitors, memantine. They haven't been tested head-to-head, but if you look at them over 18 months, they're slightly better cognitive effect for the cholinesterase inhibitors and the anti-amyloid drugs. They're oral, they're not disease modifying, but they're cheaper with few side effects, and the side effects tend not to be serious. However, they certainly don't disease modify. So how does that leave prevention in this age? It's not a competition. I copied the CDC cholera guidelines on your right, and they say what to do to avoid getting sick with cholera. They say drink and use safe water, wash your hands a lot of times, clean up safely, and that's basically prevention is all is the big thing to prevent getting cholera. Rapid rehydration for cholera works for 99% of people, and antibiotics shorten illness. Nobody suggests that we do not try to prevent the illness. I think it's the same with dementia. Both things, it's always going to be excellent to prevent. Whatever we do, some people will still get dementia, including Alzheimer's disease, and they need excellent care, starting with diagnosis. Clearing amyloid doesn't stop progression. And amyloid is not the only problem in Alzheimer's disease. If it was, then it would stop prevention. But most people who don't have either a mixed dementia or have other causes, treatment's expensive and burdensome, and there's relatively rare but serious side effects. So what should we do? Be ambitious about prevention. We've got clear strategies. We have multi-domain interventions. It's very important to include people who are most at risk and target the risk and tackle it, providing more years of healthy life and a compression of morbidity, or prevent dementia ever occurring, because that saves money. And most vulnerable people, also because it saves money, most vulnerable people stand to gain the most. But I think the most important thing is that that's what people want. People want to have more healthy years and fewer sick years. Be ambitious about treatment. Diagnose people, give information, sort their medication so it's simple and takeable, and increase and maximize physical health, which has been shown to be massively disease modifying. Plan decision making while people can make it. Care for the carer. Having dementia, looking after someone with dementia tends to make people depressed and anxious, and we know how to help. Consider cognitive stimulation, treat neuropsychiatric symptoms, assess the risk. Are they going to drive into people? Are they going to set the place on fire? Are they going to take a side, be taken advantage of financially, and manage them? Think about activities of daily living and social care. Offer people research opportunities. People like it and we like it too. Give medication as appropriate and follow up people from when they need help. Thank you for your attention. This is Jeremy Bentham in UCL, who started UCL as a great liberal university, never got to America. And so they took him to America after he was dead. And now the discussion starts.
Thank you very much, Jill. It was a fantastic presentation, new data, new ideas. We're delighted you were able to join us and to share all this knowledge with us. Now, I'm going to share my screen for a second just to show how is the agenda coming. But basically, we have the roundtable. And in this roundtable already, we got several questions for the attendees in advance, and we are privileged that our also a consultant lead this discussion. And part of our roundtable discussion, we have, of course, Dr. Jen Brilett, the scientific director of the Institute of Aging. We have also Dr. Sandra Black, professor of neurology, University of Toronto. I saw her right now in the audience. We have also Dr. Sean Whitehead, who is the co-lead of the Western Institute of Neuroscience and co-lead of our platform. And myself, I will try to not talk too much to allow Dr. Gill Livingston to respond to everything. And I know Howard Cherko is in a clinic, so he will try to join us. And also Professor Howard Cherko, who is the director, scientific director of the CCNA. So importantly, we're very fortunately, we have Susan Shaw, who is a person with lived experience with mild cognitive impairment. She was a participant in our multi-domain trial, the Synergic 2 trial. And I think it's very important to get the opinion, the reflections, and the thoughts of the people already dealing with the cognitive impairment. So we are very privileged to have Susan Shaw, or Sue, as we call her, as part of our roundtable. Thank you very much for joining us. Lauren, I'm passing the baton to you.
Wonderful. Thank you so much, Manuel, and thank you for the introductions. Just before we get into the questions, Jill, you mentioned that you didn't trademark the drawn lines image, but maybe if people love it so much, you can start putting it on some mugs and t-shirts and selling it as merch at conferences to cover the cost of the interventions. All right, now we'll jump into some questions. So there were some that were submitted ahead of the talk today, and some that are just for the panel. But I think there was a really interesting one we received ahead of time from someone who works in a community dementia service agency, and some feedback that they've gotten around risk factor prevention. Specifically, they'd like your take on, because obviously there's so much risk that you found in your research that is modifiable, and there's a lot more messaging that dementia is preventable now, but in many cases, there are still factors that are beyond our control or non-modifiable. How can we balance public messaging about dementia risk to recognize that a big dent can be made in risk reduction through good public health policy and prevention, but it's not one's fault necessarily if they develop dementia later in life? It's not like they didn't do enough earlier. How do we kind of balance those two things to make sure it's a constructive conversation moving forward?
Yeah, I mean, I think you're absolutely right. It's a problem, and I was outraged when somebody recently said to me that somebody that had developed dementia and that their friends all said it was their fault because they had not taken menopausal hormone therapy. Outraged for two reasons. First of all, it's not true. It doesn't prevent dementia. And secondly, blaming people for illness is an appalling thing to do. I think that what we can do is we can say to people, we give you power. You can do things which make a difference and which decrease the likelihood. What we can't do is guarantee that you won't get it. Some people will continue to develop dementia. And I think that it's really important to be very, very clear that we give you tools, we give you hope. We can't give you a guarantee.
If there are any other panelists who want to jump in and add on, I know Susan, I think, is our representative with lived and living experience. Feel free to jump in as well, or other panel members.
I want to add something very quickly, housekeeping. For the panelists, if you want to see the face of all of you together, there is 3 dots in the upper right corner of each speaker or panelist. And if you select one dot that says pin, you press the pin and you pin the speaker, you're going to see the 5 or 6 members of the roundtable together. Just a housekeeping Zoom technology. And Sue, I don't know if you have any comments to provide to us. You need to unmute, Sue.
First off, I feel very honored to have been asked to join this very prestigious group. It was this has been very, very interesting to me, and I'd just like to give you a quick background as to how I come to be in the study. Before retiring, I had a 30+ year career in a large company. I was a department manager and a member of the management team. So I had to have a good memory, and at that time I did not have memory issues. While working in 2015, my diabetic mother was diagnosed with Alzheimer's. And within about a year, it was obvious to me that my mom and dad needed a lot of help. In addition to this, my daughter became pregnant and let me know that I needed to retire to help look after the baby. So in 2016, I retired. I became caregiver to my parents. It wasn't only a few years later that my father was diagnosed with dementia and prostate cancer. So as time went on, looking after my parents and my granddaughter and my own household, I became very busy and very stressed. So by 2024, I felt that my memory was declining, especially in the areas of names of people, places, and things. And I was having lunch with a friend one day, and I mentioned it to her that I was really concerned because this isn't me. And she had read about the study on online, and she referred me to it. So I signed up. I came right home and signed up, and I was just thrilled a couple months later to find out that I'd been accepted. And as I went through the assessment and then the year-long study, everyone was just wonderful to me. They were, and Kurto, my coach, she's a wonderful person, wonderful coach, and very encouraging. I followed the food plan. I did the brain exercises. I did the physical exercises, the MEMO assignments, and the daily synergic charting. My family made comments about how anal I was about all this, but with my mom having had Alzheimer's and my father dementia, it's definitely in my mind, and it's important to me to do everything I can, to block it or try to prevent it as much as I can. I had a few setbacks during the last year or so. I lost both of my parents, and obviously I found that stress affects the brain. When my study came to an end last August, I was feeling absolutely fantastic, and I didn't want to lose the progress I made. So I asked her if she could help. She did this, of course, by sending me video exercises, and she recommended I sign up for Brain HQ, which I've been doing ever since. I continue to track my food. I think it's a good thing to do. It just keeps it on your mind. And I was doing fabulous. I developed a few health issues in the fall, and I had some surgery in January. And I don't know if this is the nature of anesthetic, but I did find, there was a little bit of setback there. I had a scope that I was put under for, as well as the surgery. So I had anesthetic twice, and I found that was a bit of a setback for me. But today I'm back to doing all my exercises. I walk every morning. I do my physical exercises 3 or 4 times a week. I do the Brain HQ 6 days a week. I chart my food, and I feel wonderful. I feel like I've come a long way, and I couldn't have done it without this study. And I have just found all this information, especially from Gill, all your information, so interesting, and it looks like there's a lot to be done for prevention. Which when my parents had this, I mean, we were referred to the Alzheimer's Society, but that was it. Like, other than occasional testing, maybe once a year or so, for them to see how far they had declined. There was no real medical support. So I just so appreciate what the efforts are here, and what you're all trying to do. Means a lot.
Thanks, Sue, and thank you for sharing some of your background as well. It sounds like quite a tumultuous couple years, but the opportunity to get involved with some of this research has been a really empowering opportunity.
Yes.
for you too. I'm wondering if, like you or the other panel members who have been involved in providing these kind of interventions, can speak to some of the pieces of the intervention that have been like a best practice to support empowerment and to support engagement of people in these programs, because it can be hard to wake up and do these interventions day in day, and like always doing your walk, always tracking your food. How do you keep people engaged in these kind of programs?
Well, I think it was just feeling the results, like feeling better, and memory, remembering better, and then just, when you're doing exercises and walking, that you just feel physically better overall, and you have more energy. I have a very, very busy life, and I need a lot of energy to keep up with it. I volunteer at a school, and I look after the granddaughter. I have a good social life. I bought myself a keyboard recently to get back into music, because I know that is good for the brain as well. So I think it's just seeing the results, that make me want to continue.
Dr. Black, I'm not sure if you have anything you want to add from a
No, I
clinical
think
perspective.
I think that's wonderful, because you're really doing what we're talking about. Just you're keeping your brain active, you're helping other people, you're keeping physically active. What I always emphasize is these really what Dr. Livingston has described. I mean, hearing and vision, obviously very important, but in your day-to-day life, physical activity, very, very important. And I'd be interested in some comments from the other panelists, because I know they were looking at what's the minimum number of steps per day would have a protective effect. Because they were like 10,000, etc. But it actually turns out 7,000 steps a day.
Yeah.
Which is 4 to 5 kilometers, which is well within the reach of most people, unless you have physical disabilities. And maybe Jill will have some comment on that. But that's very doable. And also, if you walk with people, if you walk a dog, you're actually helping your brain and helping your body. So that's one thing. The other thing that wasn't mentioned is sleep.
Oh, my sleep has improved greatly.
So restorative sleep is extremely important, because during your slow wave deep sleep, you need about 6 hours. During slow wave sleep, you're literally pumping garbage out of the brain, including amyloid. That's why you get the amyloid along the vessels. It's called amyloid angiopathy. So restorative sleep is very important. Treating sleep apnea, because if you're apneic, your brain goes into alarm mode. You wake up, you don't sleep properly. So sleep apnea needs to be detected, needs to be treated as much as possible. So that's sleep. What you eat, I think we've talked about. Fruits and vegetables, high fiber vegetables. Vitamin D is very important. If you don't get enough, maybe take vitamin D, a couple thousand units.
I do.
So there's a lot you can do. And the other is social engagement, which sounds like you're doing. You're looking after somebody, you're meeting with people, and that keeps you stimulated, just interacting with people. I mean, you're interacting with people who needed care, and so they were not as able to have a conversation or argue with you other than if they didn't want a bath or something, right? But there's so much you can do within your own lifestyle that can help prevent and protect. Now, I'm also very involved in clinical trials, and I'm happy to discuss that a bit later, including the secondary prevention trial, which is going on, where the idea is you remove the amyloid before it triggers the tau. I'm happy to talk about what triggers the tau, maybe when we get into further discussions, and whether the amyloid removal is going to be meaningful. Maybe the most meaningful time to remove the amyloid is before the tau has been triggered. We can talk about that a bit later, but I'll hand over to someone else.
Wonderful. Go ahead, Dr. Livingston. I think you've got your next comment in line.
Yeah, I wanted to say how important I thought a couple of things that Sue said were. One of them is that whether or not this will make a difference in other ways, people feel better, increases their quality of life. And some people weren't going to develop dementia anyway. Some people, we know that naturally 1/3 of people with MCI get better, and it's impossible to tell. It's a bit like having a vaccine and you don't get something. But whether or not it prevents dementia for you, it will make you feel better. And I think that's a really important message. That's important for your quality of life, it's important for your general health, and you'll feel better. And then the other thing you talked about was this virtuous cascade that you get involved in. You were able to do things, and then you did more, and then you did more, and they all began to work together to look after yourself. And even when you had a setback, of being unwell and not being able to do things, you got back on that road again. I think both of these things are very important. That everybody who does these things, and some of them will still develop dementia, will feel better, and will be able to enjoy life more. And that when you begin to feel you're controlling things, you're empowered. And actually, you said a third thing that was very important is that taking part in research is something. I think sometimes clinicians are a bit worried about asking people to take part in research, but most people actually like it. They like giving back. They like being useful. And also they tend to get better care because they're seen more. So I think these things are very, very important messages for you, but also for people here in the future, that when you see people day to day and ask them to take part in research, that for many of them, it will be a gift, whatever group they're in, and they will have a better quality of life, and they will know that they are continuing to be very useful, not just to themselves, but to everybody.
Mm-hmm.
Go ahead, Dr. Riley.
Thanks very much. Actually, Jill just made many of the comments that I was going to make also, that just participating and engaging and being physically active and adopting many of these lifestyle modifications can actually make people feel much better, and that then can help the perception of memory dysfunction and associated factors. And what it brings to mind for me is the public health and the educational aspect of conveying this information in a public setting, so that there's more understanding in the general public about the value that can be obtained from this, and less fear around and stigma around dementia as well. So, I mean, reducing stigma, reducing fear, certainly for the older population. Developing cognitive impairment seems to be one of the greatest fears of the aging process, and so trying to tie that to an understanding that there are things that can be done, maybe won't stop you from developing cognitive impairment in the longer term, but could change the course of the disease, the trajectory, the onset, and that health that comes along with developing many of these lifestyle modifications can be very rewarding. So that then brings me to another thought that I had, and it comes back to your comments, Sandy, about 7,000 steps. Very doable. And I when you said that, I actually looked at my watch that has a step counter on it, and I realized I'm only at about half of my required steps for the day. So better get moving after this. But it made me think about those who are not able to participate in that fashion, and what have we actually done to look at alternatives? So people who maybe are not highly mobile, people that can't participate in that way, can't necessarily go for a walk in nature. Do we have other recommendations, other alternatives that can come forward? Sandy, you've obviously got some. So I want to put that question forward then.
So sometimes a reclining bike.
Great suggestion.
Good for people with knee problems and so on. Yeah. So that's something. Now you have to be somewhere where they have the reclining bikes, but wise do it, but places do, and so that can sometimes be useful. You know, people with Parkinson's disease also. It was found that when they're not too impaired, but when they dance, they can do a lot more than when they walk. Yes. Because the music actually makes them, use their brain in a different way. So there used to be, before the pandemic, there was dancing with Parkinson's, and they had the YMCA's. A lot of people were doing this. The pandemic took a huge bite out of that, and it hasn't sort of been restored in the same way. But Parkinson's can also be associated with Alzheimer's disease. They coexist. So those are things, again, that are available for people to consider. But with Parkinson's, you have to be careful because you can also fall. But they can dance better than they can walk sometimes. They're using a different system of the brain. So that's another consideration.
Yeah, that's a great suggestion. So I guess what I'm really advocating here is for us to look for alternatives to add into there are many great suggestions for all of these lifestyle modifications, but then looking for alternatives to make them more inclusive.
Absolutely. And just highlighting Nicole Anderson's comment as well of, the cultural tailoring for that as well. And whether we call it exercise, it's a gym or something else is something we need to consider in the marketing for all this stuff.
Having fun.
Yeah. What you stand to gain, not like another chore, another thing on your to-do list, hopefully what you gain. Go ahead, Manuel.
Well, thank you very much, Sue. You are our best ambassador for the Synergic trial. For those that joined late, the Synergic trial is a clinical national trial in where we apply multi-domain interventions following the finger model and 550 people with MCI. We're delighted to announce that we have recruited 500 individuals, almost 500 individuals in this trial. I think it's one of the largest trials in MCI in Canada in the history of the trials in MCI. And so it's one example how we're doing that. And I would like to add two things concerning the comments about the kind of exercise for those with limitations. I think one of the secrets, as we spoke before with Dr. Livingston, is the effective coaching. And Sue said marvelous things about Kerto Ahmed, who is one of the coaches in our trial, in where we tailor the exercise based on the necessities, but also the limitations of each participant. Even we have exercise that the participant can do with a chair, sitting in a chair with some elastic bands, because the idea is the effective coaching and how we progress that. So we believe that the intervention is not only working because of the intervention itself, but also because the effective coaching helps to change behavior and in the combination of those interventions. Aligned with that, CHR recently funded our team under CCNA in order to create guidelines, because today in my clinic, if I need to prescribe exercise for brain health or cognitive impairment, I don't have a clear guideline. I have several guidelines. We don't have a Canadian guideline. So we want to create these Canadian guidelines, how to prescribe exercise and cognitive training to improve cognition and delay dementia. So we're working in that in order to offer that to clinicians for free, because to prescribe exercises is to how we prescribe antibiotics. I don't prescribe just antibiotics. I prescribe ciprofloxacin or demersasan or whatever. Exercise is the same. We need to be specific. It's no exercise in general. And coming back to the talk and the lecture of Dr. Livingston, I love, as you said, this approach is complementary, and it's not in competition. We need to work together. Those that were doing research and clinical treatment in prevention of dementia, but also those with new medications, new potential modifiable therapies like the anti-amyloid therapy. Saying that, something very interesting is that in real life today, we do know that only in a small percentage of individuals with MCI or early Alzheimer's disease qualify to receive anti-amyloid therapy. There is several exclusion criteria. For example, here in Canada, you're almost goes for a 0.4. We cannot prescribe it because the risk of the best event is not approved. So in real life, depends on the series you read from the United States or Europe, is between 10%, 15%, meaning 85% of the people with cognitive impairment due to MCI or Alzheimer's disease may not qualify for the treatment. And today, sometimes we don't offer other alternative. So, patient may come to the clinic with all the hopes for this new medication, anti-amyloid therapy, and we say, well, I'm sorry, you don't qualify. So, and I think that's an opportunity to offer those individuals and to stress the value of lifestyle interventions, vascular risk factor controls, and so on. And it's an opportunity to partner all this movement about clinics, infusion clinic for this anti-amyloid therapy, and work together on this. And I would like to listen to the thoughts of Professor Livingston and the panel on this.
Yeah, I think there's two things to say about them. First of all, well, several things, but one, of course, it's not competition, and it is absurd to suggest that we should have one and not the other. But secondly, we're very early on in the life of effective drugs for disease modification, and I think it's extremely likely that the drugs will be more effective, more deliverable and cheaper quite soon. And perhaps for more people and more indications. So I think that's not necessarily a lot of help to an individual, but it's a lot of help to think that we're at the beginning of this. And to say to people, not just that this isn't indicated for you, but it probably won't help you and it might have a lot of side effects and be burdensome, but we have a lot of other things that will make a big difference to you. And, you know, I could but won't go on in some detail about the list of the things that I had in the second last slide of things that we can do to help people that really can change their lives in the future for them and their families. So I think that we can do a lot, and we should try and couch it positively and say there isn't an indication that this would help you and they are burdensome and diseases with side effects. You know, we're continuing to hope that there will be better drugs. And also that we would be great if you would take part in research. And if we haven't got something now, you know, we keep in our clinics a research register, and we have permission to approach people for research, and nearly everybody says yes. So that we then have them for the future for whatever different research that we're going to do. And all the people on this webinar are going to be doing lots and lots of different research. So I think there's a lot. And then, yeah, finally, I would say about doses of exercise. I think we are talking often about quite old, and not everybody, but quite old and disabled people. And I think the message that increasing a bit can make a big difference is very helpful. That like Manuel and Art, we have chair-based exercises for people who can't move. And I think if they hear they should be doing 7,000 and they can't really walk at all, that's very dispiriting. So I think that doing a bit more makes a big difference is a very important message. And if they do a bit more, they can often then do a bit more after that, begin to get better. And I think that that's part of it, and part of coaching, individualizing things to somebody rather than saying, well, you can't get out of your chair, but if you walk 7,000 steps, you'll feel a lot better, because it doesn't help.
So can I just comment further on that? Mm-hmm. So I think originally it was 10,000 steps, and then they did some studies and showed that 7,000 steps have the same benefit. But obviously you have to be able to walk, and have to be able to walk safely. And in some of the cities and towns, then you're going to get more air pollution problem, right? But I wanted to also point out that there was a very interesting study about primary prevention related to exercise. I don't remember when it was published, but it was several years ago, and it was looking at along the life course, when was the most important time that you exercised? And the surprising result was, because they actually looked at different, like teenage, different, like, you know, kind of young, like early 20s and 30s, went all the different stages. And the result was the most beneficial impact using some cognitive and other measures was actually teenage years. So people who were exercising and very physically active in their teenage years seem to have more protection in later life. Maybe it's because they developed the habit. Maybe that was very formative in terms of their brain development. But I thought that was very interesting, that this would be something that really, this is a real primary prevention. You start it in your youth and you keep it up throughout your life. That's probably the best advice to give people. So the 7,000 steps was just an example of, we were looking at 10,000 and different sort of limits. But then I think modifying how you exercise if you can't walk, and that's why I think, you know, reclining bike or other ways to compensate is still a way to be able to do some of that. But I just thought it was interesting that it was teenage that seemed to have the biggest impact. Very interesting.
Yeah. And adding in a note about the 10,000 versus 7,000, the 10,000 was actually a marketing number that was invented by a pedometer company to sell some pedometers in the 60s. So it's not evidence-based, but still very effective because we're still talking about it today, you know, many, many years later. Related to some of the discussion we've been having around prevention and treatment and how these aren't really just two separate things. They often happen both together. They're all tools in the toolbox that we have. Is there any evidence or practice that's been done around how to modify prevention and lifestyle prevention when someone starts anti-amyloid therapy? Are there any changes that people might need to make to their diet and lifestyle factors when they're going through these treatments?
Can I speak to that? Because I think we're actually doing it.
Yeah.
And the answer is all the things that we've talked about are relevant. But here's something interesting. It's called secondary prevention. And the secondary prevention is now underway using anti-amyloid therapies. It's lecanemab. It's the 345 study. And the idea is you have amyloid accumulating for 20 years before you're aware that it's even there. And the idea is to get rid of it before it triggers the tau. We'll come up to what triggers the tau in a moment. So there is a study underway in North America where people have to have the amyloid deposits. And this actually is Lisa Sperling, who thought everybody, when they got to be in their 40s, just like you had your hearing checked and your eyes checked, you get an amyloid PET scan. It'd have to be cheaper. And if you had amyloid deposits in the brain, you just get rid of it. And if you keep up with that, then basically you don't trigger the tau. The amyloid still can be harmful, but it's really when it triggers the tau that the full disease takes off. And just recently, we found out what seemed to be triggering the tau, because the tau is in the mesial temporal part of the brain, the entorhinal cortex, hippocampus. And most people, when they're by their 80s, they've got tau, they've got TDP43, they've got these pathologies in their hippocampus, which is why memory tends to get worse with each decade over 50. So the idea is to remove the amyloid before the tau takes off. And one of our fellows, using ligands from the Montreal, Douglas Hospital, Montreal, where they have lots of ligands that they've been following over the years, using PIB for amyloid, MK6420 for tau, and also something called TSPO for inflammation. Now, the inflammation the TSPO detects is actually activation of the microglia and the astrocytes. So as the amyloid accumulates, the amyloid is trying to be ingested by the microglia, and the astrocytes are trying to protect that stuff getting into the brain. And eventually the astrocytes just run out of steam. They just can't do it anymore. They're full of amyloid. That seems to trigger the tau, because this TSPO attaches to the inflammation of those two cell types. And what the fellow found was when it attaches to those areas in the brain, which are the signature areas of Alzheimer's disease, then the tau starts. And it's like, it's the last resort. We need help. Please come and help us. So tau comes out of the mesial temporal region, and it goes to the cortex, and it tries to help with the fight against this. It's a neuroimmune response. Alzheimer's disease and the amyloid and tau are trying to protect against injuries and viral infections. So there's now some more insight into what's triggering the tau. Because if you can get the secondary prevention, which is what they were doing with the AHEAD study, is getting rid of the amyloid before it had a chance to trigger the tau. So in a sense, they were releasing the duty of the microglia to get rid of all these amyloid chunks. So I think the more we understand about the disease, I mean, in fact, Dr. Sperling thinks everybody should have an amyloid PET in their 40s. If you've got any amyloid, just get rid of it. And then the tau has to stay in the mesial temporal region forever. And when you're in your 80s and 90s, yes, you're going to have some problems because the tau is there, but by then they're not so useful to mankind. So you don't why worry about it.
Yeah. I'm just going to ask one more kind of closing question to wrap up here, acknowledging it's getting late for Jill and it's around lunchtime for me on the West Coast. But looking ahead 5 to 10 years, what are some things that you think are essential for scaling up equitable access to integrated prevention and treatment strategies for dementia risk reduction and treatment? I'll open
Maybe
that up to any panelists. Go ahead, Sean.
Yeah, I haven't had a chance to speak, but
Sorry.
mostly because I'm the only non-clinician on this call. So, one of the things I think it kind of feeds into this. One of the things that Sandra was saying and Jill was saying is that you can't do prevention without proper screening, right? And it's amazing to me that when I think about when you hit a certain age point, you get routinely screened for various types of cancers, and yet we have no real screening protocols in place for any neurodegenerative disease. And as it's been said, a lot of the changes that happen in the brain happen decades before symptoms are even onset. And so the issue potentially with the anti-amyloid therapy is, and as Dr. Livingston was saying, is that it's got some modest effect on the cognition, but it doesn't mean it's the wrong therapy. It might simply be a timing issue. And so when I think about the cognition piece or any of these sort of intervention trials, it's about targeting the right time. And we know that with every decade of life, the metabolism, the brain-heart connection, all the things that sort of drive brain function and optimize brain health are fundamentally different with every decade of life. And so it's challenging to sort of disentangle those two things. So when I think about the equity piece, really it's about access to like screening, right? And so we need to be thinking about how do we develop screening techniques in a way that is equitable and accessible, because certainly that wouldn't be PET scans, right?
Well, the plasma biomarkers, right? Which there's a lot
Sure.
of data, those are becoming much more available. And the p-tau 217, 231 seem to be telling you that there's amyloid deposits in the brain. And so I think the plasma biomarkers are going to be sort of revolutionary.
Yeah.
That's,
Yeah, I absolutely agree with Sandy on that. The advances in this area are remarkable, and the cost is not that great. And it's, in theory, it's the sort of thing that can be done at the population level and around the world. So I would guess that within the next few years, certainly the next 10 years, probably, based on what I hear coming out of, World Dementia Council and ADI and all of the other organizations that monitor worldwide, that will be the case.
And Jill wants to say something. Go ahead, Jill.
Yeah, I think the blood biomarkers are a massive advance. p-tau 217 just looks like the best blood biomarker. There seems to be an overdiagnosis in primary care. And I think we have to be very careful of all of these things. In the very long time I've been working in this field, it's always been that in 10 years we would definitely have the answer, and we haven't. So I think that I'd be really, really interested to know what, do these treatments work if you're in your 40s, or are they massively expensive, massively burdensome, and have huge side effects when the majority of people with amyloid in their 40s will never develop dementia? We have to work on the evidence within that. But I think that whatever that we won't be. I don't think we should start screening until we have things that we can do with the screening. I really don't think everyone wants to know. I think we should only be screening to be in trials. I don't think everyone wants to know at the age of 40 who has amyloid and who doesn't. There's nothing we can do. But if we should be, we're not going to PET scan anyone soon, I think. It will just, not for amyloid, or almost nobody. We'll be doing p-tau 217, and it will be going to the lab down the road very soon. It might not be quite as quick as use and ease, but it will be pretty rapid, and it will be pretty available, I think. It's been hugely important, and we just need to begin to work out the false positives, and then we need to know whether the hope that Sandy has and the hope that I have, but possibly not quite as, I'm not quite as convinced as she has that works. And we will know. We're waiting for the results of many of these trials. And also of the AHEAD trials of people who are developing who would develop Alzheimer's in their 40s and have little other brain pathology, and that give us some more pure idea about it, and we will have a lot of answers. So what I hope is that we have these answers, and that we have manuals and anybody else's guided apps, which everybody gets in a midlife brain check and work through. So fewer people get the problems, and the people who have the problems get better treatment, I hope, but I'm not 100% sure.
Mm-hmm. Just
Can I
noting that.
comment?
I would say that's a great way to close the
No.
Sandy, do you have just a
Well,
short
it's just
comment,
that the
Sandra?
ApoE4, some of these risk factors, like the ApoE4, is available through Dynacare and so on. There is also an autosomal dominant type of Alzheimer's disease where you get sick in your 20s, and they're in these trials as well. Their brains are younger, and they're usually dead by their 40s. This is the autosomal dominant type of Alzheimer's, very rare, but those are also in trials. And there you have a young brain that's been accumulating for 20 years, and they're going to be dead in their 40s. So that's another development where, these secondary prevention trials are kind of underway, because people are usually relatively normal.
Thank you very much. I think that is great to start closing. I don't know if Jill wants to do some final word, or Sue. I think Sue want to say some final
Who should
word?
have the last word?
If I can say something quickly, from where I sit, and I volunteer in a school, so I see where I see a big void is, the children's lunches. Some of them are great, and some of them are nothing but these little packaged processed foods, and they have treats that the kids can buy in school. I think there's a real void there. There's no commercials on TV to encourage people when they're young to eat properly and exercise, and that, so you don't get dementia. Like I don't think there's anything on TV like there is for some other, there's prevent smoke or stop smoking and all that stuff, but there's nothing about dementia. And they're on their screens, they go home, they're on their screens, and all this endless scrolling. And I don't think this falls in your areas because you're more research, but I think there's a void there, and with more communication on TV and that, maybe start teaching people younger the importance of the lifestyle aspect of this. That's just from where I sit, what
Great comment. Great
In
comment.
fact, it's dangerous because it can do social harm. These social media and children can get a very upsetting experience. I think they need to be protected. Probably until they're 18, but that's not going to be possible to even have access to the social media. Because that's really where lots of really bad stuff happens. And we're not on top of it.
Great comments. Great way to close this excellent webinar and lecture for Professor Livingston. I want to be respectful of the time for everyone in the call. And we have a small token of appreciation for Dr. Livingston that we're going to courier to you to UK, because I cannot give you through digitally right yet. Perhaps in the future we can do it with all the advanced in digital technology. But thank you very much again for making the time and to share with us all the important research you have spearheaded from the beginning, but also continue right now, that have changed not only research, clinical care, but also policy, which at the end of the day, that's the way we do research, right? Just to try to make better life for our patients, caregivers, population in general, and policy. I thank also everyone in the panel, Dr. Riley, Dr. Whitehead, Dr. Black, Lauren, Kelly, and Susan Shaw. Thank you very much for joining us. And everyone that was able to attend today. We had 162 attendees. Now I see we still have 50 people despite it's very late. So we're very glad for that. So thank you very much. And for those that need a certificate of attendance, email us. We're going to send a certificate of attendance to the webinar. Otherwise, have a great afternoon, a great evening, Jill. And we're going to see you probably in the next conference. Thank you very much, guys.
Thanks very much for organizing.
Thank you, everyone.
Bye-bye, guys.
Bye.
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 Thank you.